Hi, my name is Dr. Haroon, and today I'm going to talk about anatomy of thyroid gland and its applied surgical aspects. Thyroid word has been derived from Greek word thyroides, which means shield shape, because it is acting like a shield in front of the neck. So it has been derived from this word thyroides. By the end of this presentation, you will be able to have brief introduction about this gland, gross anatomy of thyroid gland, what is the embryology, what are different relations of the gland in the neck, what is the blood supply, lymphatic drainage, nerve supply, and what are the associated nerve injuries during surgery in this surgery of thyroid gland. Thyroid gland is the largest endocrine gland in the body, weighing around 25 grams, and it produces T3, T4, and calcitonin. An abnormal enlargement of the gland is called goiter. As you can see in this diagram, thyroid gland is butterfly in shape, which contains two lobes, right lateral, and left lateral lobe. And both these lobes are joined together through isthmus. The central part is called isthmus, and there is a pyramidal extension of the isthmus called pyramidal lobe. Thyroid gland is located in front of the neck in anterior triangle between the two sternocleidomastoid muscles. The vertebral levels of thyroid gland is from C5, 6, 7, T1. You can remember it with the root value of brachial plexus, which means C5, 6, 7, 8, T1. So similarly, the vertebral levels of thyroid gland is from C5 to T1, as you can see in this diagram. Then the tracheal rings, thyroid extends from middle of the thyroid cartilage up to the fifth or sixth tracheal ring, and the isthmus is lying against the second, third, and fourth tracheal ring, and there is pyramidal extension which may extend up to the thyroid cartilage. There are two capsules of thyroid gland. One is called true capsule and one is called false capsule. True capsule is actually the peripheral condensation of the connective tissue of the gland. This green line in this diagram is showing true capsule. And all the blood supply, intraglandular blood supply, is inside the true capsule. And then there comes a false capsule, which is actually pretracheal layer of deep cervical fascia. The red line in this diagram is showing false capsule, which is actually a pretracheal layer of deep cervical fascia. And there is a very commonly asked question that what is Barry's ligament? So Barry's ligament is actually condensation of the pretracheal layer of deep cervical fascia, or you can say condensation of false ligament in the most posterior medial aspect of the gland, where it is firmly adherent to the cricoid cartilage. This diagram is showing clearly that what is Barry ligament. You can see thyroid gland is adherent or firmly attached to the cricoid cartilage with this Barry ligament, which is actually condensation of pretracheal fascia. Thyroid gland is developed from the base of the tongue where the foramen cecum is lying. There is an endodermal thickening at the level of foramen cecum. This endodermal thickening elongates downward as thyroglossal duct. It continues to elongate downward and then it bifurcates at the lower end. These bifid ends enlarges to form thyroid gland. As you can see, two lateral lobes, and in between there comes the isthmus. This is very important vital question, that why thyroid gland moves with swallowing or deglutition. There are few reasons behind this. When in early phase of swallowing, hyoid bone moves up. When hyoid bone moves up, it pulls the pretracheal fascia in upward direction. When pretracheal fascia is moved up, it pulls the Barry's ligament upward, and because thyroid gland is attached to the trachea or cricoid cartilage with Barry's ligament, so by the movement of Barry's ligament upward, thyroid gland moves upward. And another reason is that isthmus is attached to the trachea. So when hyoid bone moves upward, pretracheal fascia moves up, trachea moves up, and isthmus moves up and it moves the thyroid upward. These are the relations of thyroid gland in the neck. This blue shaded area is a thyroid gland. You can see, first of all, after the skin, there comes investing fascia, which invest the strap muscles of the neck. As you can see, sternocleidomastoid, sternohyoid, sternothyroid, and omohyoid. These muscles are invested by investing layer of deep cervical fascia. Then there comes the pretracheal fascia, which surrounds the thyroid gland, trachea, esophagus, and recurrent laryngeal nerve. So all these structures move upward when swallowing takes place. And in the posterolateral aspect of this thyroid gland, there comes a carotid sheath, which contains a common carotid artery medially, and internal jugular vein laterally, and vagus nerve in between, with sympathetic chain behind that. And the most posterior aspect of the neck is prevertebral fascia, which is lying anterior to the vertebral column. There are two main arteries which supply the blood to the thyroid gland: superior thyroid artery and inferior thyroid artery. In only 3%, there is a third artery named thyroidema artery, which usually arises direct from the aortic arch. Whereas superior thyroid artery is a branch of external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of subclavian artery on both sides. So two arteries, superior thyroid artery in upper pole of the thyroid gland and inferior thyroid artery in the lower pole of the thyroid gland. But there are three veins which drain the thyroid gland. There are two arteries, but three veins. As you can see, superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Superior and middle thyroid vein drain into internal jugular vein, and inferior thyroid vein drain directly into brachiocephalic vein. There are sometimes another named vein called Cocker vein, and it also drains the lower pole of the thyroid gland, and it is usually drained into the internal jugular vein or sometimes into the brachiocephalic vein. So two arteries, superior thyroid artery and inferior thyroid artery, and three veins, superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Then comes the lymphatic drainage of the thyroid gland. Thyroid gland drains into upper and lower deep cervical lymph nodes, as you can see, pharyngeal lymph nodes and jugular-digastric lymph nodes, and pre and paratracheal lymph nodes. These are pretracheal and these are paratracheal lymph nodes. Pretracheal lymph nodes sometimes are also called Delphian lymph nodes, and they are level 6 lymph nodes of the neck. There is a dual nerve supply of this thyroid gland. Parasympathetic supply comes from vagus and its branch recurrent laryngeal nerve, and sympathetic supply comes from superior, middle, and inferior cervical sympathetic ganglions, and mainly from the middle cervical ganglion. There are two very important nerves which are in relation to thyroid gland, and they are very important from surgical point of view. Superior laryngeal nerve is related to superior thyroid artery, and it is located in the upper pole of the thyroid gland. It gives two branches: external laryngeal nerve and internal laryngeal nerve. External laryngeal nerve is a motor branch, and it supplies cricothyroid muscle, and injury of this nerve causes loss of high-pitched voice. This is very important MCQ and Viva question as well, that if injury of the external laryngeal nerve takes place, what happens? So loss of high-pitched voice takes place. And internal laryngeal nerve, which is a sensory nerve, and it supplies the mucous membrane of the larynx above the vocal cord, and when it is injured, it causes choking post-operatively. As you can see in this diagram, this is superior laryngeal nerve, which is a branch of vagus nerve, and it comes along the superior thyroid artery, and then it divides into internal laryngeal nerve and external laryngeal nerve. The external branch of superior laryngeal nerve is the most commonly injured nerve during thyroid surgery. It is located in the upper pole of the thyroid. So to avoid the injury of external branch of superior laryngeal nerve, the upper pole should be ligated under vision, and it should be ligated as close to the thyroid as possible. The second most important nerve in relation to thyroid gland is the recurrent laryngeal nerve. It is related to inferior thyroid artery and a branch of vagus nerve. It has motor and sensory supply. The motor supply is to all intrinsic muscles of the larynx except cricothyroid, which is supplied by external branch of superior laryngeal nerve. And then the sensory supply is to the mucous membrane of larynx below the vocal cord. Above the vocal cord, the sensory supply is from internal branch of superior laryngeal nerve, as I have mentioned in the previous slide. So in this diagram, you can see this is the right-sided recurrent laryngeal nerve, and this is the left-sided recurrent laryngeal nerve. This is very important question being asked in exams, that why do you call it recurrent laryngeal nerve? The answer to this question is that because it when it comes down, it reoccur again and moves upward by hooking around the subclavian artery in the right side and arch of aorta on the left side, and then it runs in between the tracheoesophageal groove. So that's why it is called recurrent laryngeal nerve. This is a busy slide, but you have to remember each and every portion of this slide. This shows that injury of the laryngeal nerve can be unilateral or it can be bilateral. And then it can be partial unilateral or complete unilateral. Similarly, partial bilateral and complete bilateral injuries. And then what happens when these injuries take place in partial unilateral, there will be dyspnea on exertion, and in complete unilateral recurrent laryngeal nerve, there will be hoarseness of voice. Similarly, in partial bilateral recurrent laryngeal nerve injury, there will be stridor or suffocation, which requires urgent tracheostomy, and in bilateral complete recurrent laryngeal nerve injury, there will be aphonia. Simply, you can have idea or you can remember that if there is partial injury of unilateral or bilateral recurrent laryngeal nerve, the problem will be related to respiration. So partial injury, problem will be to respiration, either dyspnea on exertion or stridor. And if there is a complete injury, either unilateral or bilateral, the problem will be related to voice of the patient. As you can see, complete unilateral injury causes hoarseness of voice, and complete bilateral injury causes aphonia. So partial injury related to respiration, complete injury related to voice problem. And this is the last slide. This is again a very important Viva question, that what is tubercle of Zucker-Candle and what is the significance of tubercle of Zucker-Candle? So actually, tubercle of Zucker-Candle is the posterolateral projection of thyroid lobe, resulting at a point where lateral and medial components of the thyroid gland fuse. So you can see this projection is actually, this projection of the thyroid gland is called tubercle of Zucker-Candle. And what is the importance of this point? That at this point, you can identify the recurrent laryngeal nerve going into the Barry's ligament, and by giving upward traction at this point of tubercle of Zucker-Candle, you can avoid the injury to the recurrent laryngeal nerve. So this was all about my presentation. Thank you very much. Best of luck for your exams.